Good morning. Thank you, everybody. First of all, I would like to thank you, the Penumbra and the Moscow Stroke Conference organization, for inviting me. And it's an important opportunity for me to share my little personal experience with all you doctors inside of this conference. My topic is the efficiency of the first pass technique, how to increase the chance of removing a blood clot with the first pass. My philosophy is, facing a stroke, you have to think and to be very fast. You have 15 minutes to get your access. If you're not, your nurse or your colleague has to make you change your chest option. Stability is a goal, so you have always to reach a good stability of your system. My choice is always the triaxial system. Karolinska and other authors push the concept of carotid balloon occlusion, but which I don't use regularly. Your guiding catheter has to climb very high as far as you can safely go. Vasospasms in some situation could be an issue, but don't be too afraid. You have something you can cope with. And also posterior circulation is something you have to reach. This is what we use regularly, Neuron Max. This is our setup, Neuron Max 19 centimeter, then the aspiration catheter, Jet 7 or 68, 3 Max or velocity. We have a lot of catheter for the reperfusion, starting from 3 Max up to Jet 7. And we have a lot of transition point, very high flexibility and enhanced pushability. These are the dimension and the compatibility of the reperfusion catheters. And this is the Penumbra, the new Penumbra engine that is very easy to use. And once you have your lead lightning is ready to completely activate the suction of your clot. This is the velocity delivery microcatheter, which is designed for deliver the 3D revascularization device with a 0.025 inner diameter. This is the 3D revascularization device with a specialized architecture designed to minimize the vessel wall contact and also has petals to trap the clot and to help you in the reperfusion of your closed vessel. We have different kind of clots, so your procedure could be different and complex, starting with fresh erythrocyte-rich clots up to highly organized fibrin-rich atrial clot, which could make a very, very challenging procedure because of their adhesion on the vessel wall. I would like to focus on this important topic, this important article made by Professor Maki from Geneva, who was an experimental evaluation of the direct thromboaspiration efficacy according to the angle of interaction between the aspiration catheter and the clot. And basically, the study demonstrates how the tip of your catheter and the interaction with the clot has to be in an angle of in a favorable angle, which has to be not less than 180 degrees or not too less than 160, because this makes your suction very, very efficient. And as you can see here, in situation like this one, your suction probably is going to be very effective, but in a situation like this, when the angle is under 125, you probably need a combined technique. And this was studied with a vascular phantom. So in proximal M1 occlusion, the direct thromboaspiration is a frontline technique. Always when you have a favorable angle. When you don't have a favorable angle, probably you have to start already with the combined technique, with the Solumbra technique. I'm showing you in some cases. This is a lady who was already recovered for abdominal surgery in our hospital. He arrived with this anatomy and the occlusion of M1 segment. As you can see, the difficult anatomy of this lady. This is the perfusion system, the perfusion study. We decided to treat the lady because the stroke just started one hour before, even if the perfusion was not so good. Ended up in a tip carotid occlusion. This is the angiography. This is the thrombus, as you can see here. And with just the first pass, we obtain a complete reperfusion of the vessel, as you can see here. She was discharged at day 7, and at 3 months she had a ranking scale like 1, without any big neurological sign. Here we have another case of distal M1 segment occlusion. This is the perfusion study. This is the anatomy. As you can imagine, probably your guiding catheter is not reaching the position you would like to reach, but the system is very good. So we went up there with our system 3 max and then with the A68. We arrive against the thrombus, and this is this anatomical situation, neuromax in this very low position, but still we obtain in 1 pass the reopening of the M1 segment with a good result, with just this little insular lesion. This case is a kind of more difficult one because it's a tandem lesion in a young lady. It's a huge dissection in the postbulbar carotid tract in the left system, and plus you have M1 segment occlusion. This is the perfusion that we are right now doing with the rapid, but by the time we were using the perfusion of the GE CT that we had. This is the dissection. We passed the dissection, and as you can see here, we were using the Penumbra guiding catheter, NeuroMax, as a PTA reaching the petrosal line. And starting at this point, we get to M1 segment, and we obtain a rapid reperfusion of the M1 segment. Afterward, we decided to PTA a little bit this dissection. We obtain an okay result, a mean, without any contrast medium stagnation, and we decide just to treat the lady with aspirin, with high dose aspirin, and that's it. And the lady was discharged with very, very little ischemic lesion in as you can see here in the MRI. Here we have a male, an 80 years old male with atrial fibrillation without any anticoagulation because he deliberately chose not to have it. Diabetes, hypertension. This is the CT scan. He arrived in a spoke hospital, and then he deteriorated in the following hours. He arrived in our hospital with an M1 occlusion. You can see the very, very challenging anatomy, and we, in some situation, in this situation, we are ready to change our access in some situation. He performed the RTPA, but in the following minutes he was worsening again, so he arrived in the angio suite. We cannot reach the ICA, so we were talking with the relatives, and we decided to go for a direct puncture of the carotid artery. This is the puncture of the carotid artery. We arrived in the M1 segment. As you can see here, there are 2 branches missing, probably the temporal, the frontal and parietal branches. And then afterwards, we obtained, with a combined technique, the reperfusion of the Sylvian system. We had some SIH, but he recovered very well. This is the occlusion of the puncture site with the angiosil, which probably you use. And at 1 year, the MRSI, the modifier ranking scale was very, very low. So we obtained a very good result. Here we have another case of a posterior circulation. As you can see here, we have already some lesion in this part, cerebellar and mesencephalic. We decided to go. We ended up in the distal part of the vertebral artery. We assessed, our access was from the left side. We arrived very high. We have our neural max, and then we, with just one pass at the tip of the basilar artery, we obtain a very good result with any kind of problem, as you can see here. The lesions are always the lesion we had before, so the result was not so bad. And this is something maybe off level that we treated in Torino when I was working in Torino. Here you have a thrombus at the bifurcation with the intracranial system that was open. So we decided to pass with a filter in order to preserve the intracranial system. And then I used just the NeuroMax to aspirate the thrombus. I obtained, I guess, a good result. This is the final result. And this is the intracranial system. So we were lucky and the situation ended up very well in a very fast way. This is another case with a thrombus again. You can see the hypodensity at the bifurcation. I did the same. I thought the same. So we decided to go in the same situation, to work in the same way. So we passed the obstruction. You know how unstable is the thrombus here. We decided to pass with the filter. We obtained we aspirate, we suck the thrombus, but we ended up with a thrombus in the ICA and the N1 segment. But we were there, and so it was so easy just to get there and to suck the thrombus and to obtain the reperfusion of the Sylvian system, as you can see here. This is a 70-year-old guy with an occlusion of M1 segment, left M1 segment, with this horrible plaque and stable plaque. In this situation, we decided to go with a stent retriever because also of the stenosis and the anatomy. Here you have the NeuroMax, and here we are deploying the 3D system, as you can see here. And the final run was really, really good with no thrombus in the system. In 24 hours, we don't have any kind of lesion in the system, in the left system. This is a 75-year-old guy with an NIH9, M1 occlusion. It was a fluctuating symptomatology because of this situation, and you probably can imagine that there is not just a thrombus inside of this artery because the basilar tip is opened. So we decide to aspirate, and the result of the first pass aspiration was good, but the result was tight stenosis of the basilar, the middle trunk, the proximal part of the basilar artery. So we decide to use a carotid cardiological stent, Onyx Resolute 3 per 15 millimeters to reopen the vessel, and we used just the antiplatelet therapy, high dose. This is the result. In 24 hours, the stent is fully opened and the system is very good. This is another guy. This is the CT. You can see already the M1 segment occlusion. This is the CT angio, but the situation is kind of different than the other cases because we had this huge pseudoaneurysm in the carotid, in the bulbar part of the carotid artery. So it was kind of challenging to pass in the postbulbar part of the carotid artery to reach the intracranial system. So it was not very easy. So we passed all this system with the NeuroMax, with this difficult anatomy with the NeuroMax, and you will see here. Okay, look, this is the NeuroMax, and then we passed with the A68 or Jet 7. Jet 7 exactly, and then we go for a combined procedure in order to reopen the system. As you can see here, this is the aspiration and the retrieving of the clot. The final run was very good, but the result in this case was not so good. So we had an hypertension in the right hemisphere and the large ischemic part in the temporal parietal part of the system. And I would like also to explain, this is kind of off-label in a male who had a chronic dissection and occlusion of the left ICA with an infiltrating NIH. And as you can see here, we have some thrombus inside of the two frontal and parietal branch. And so we decided to treat in a particular way. We passed the communicating anterior artery with the velocity, and we decided just to use a low dose of RTPA in order to clean up the branches. You can see here the thrombus, and this is the result afterwards. And the MRS modified ranking scale of the male in the following days and after 1 year was 0. So if I have some take-home message to give, I would say that you have to work on your stroke team first, multidisciplinary approach, emergency doctors, stroke doctor, anesthesiologists, and neurosurgeons has to be involved in your system. You have to train and cross-train your group, nurses and technicians. You have to go for a standard procedure always, then you can move forward for a different one. If the situation changes, you can move in another direction. Adaptfort is my first option if the anatomy allows you. If in other situations, you have to be ready to use the stent retriever. Triaxial system to me makes a big difference and helped me a lot. And the other point is size your target vessel. So you have to choose the vessel you're going to treat, and you have to size the catheter you're going to use. Get ready for a rapid change and an unexpected procedure, because the stroke, is something that could be very effective and very easy in some situation, but could be a nightmare in other situation. A complication today may lead to a solved issue tomorrow. So don't get depressed if some cases doesn't go in the right direction. And never forget, we are very lucky to serve in this unbelievable time. And after all this, I have to say just spasibo, and I will never stop being grateful to you. Thank you so much.